Yes, thank you, Dr. Ifine, for the introduction. Good evening, ladies and gentlemen, members of the NSA. Uh, without wasting much time, we will, I think we have up to 88, 85%, 84 participants, so we can start. Today we're going to into our ninth, it's our ninth webinar, second session. We have in the house distinguished Dr. Kingsley Ufoma Toby, who is going to be our speaker for today. So, Dr. Kingsley, you're welcome. Without wasting time, you can go ahead and start. You have 45 minutes to speak maximum, and then we can give you 5 minutes extra. Everybody who wants to ask any question can keep it. You can. There will be a 20 minutes question after the session, after the speaker has finished. Then participants during the session can also type in comments and questions in the question box. So thank you very much, Dr. Toby. You're ready, you can start.
Thank you very much, Dr. Rabiu. I appreciate this opportunity. I'd like to also thank Madam President and Busola, so I call her, and Dr. Dati, and the leadership of Nigerian Society of Anesthesiologists. Today, we're going to be, I must not fail to recognize some of my mentors here, senior colleagues. Thank you so much. So today we're going to be looking at the management of traumatic brain injury, a very topical issue in our purview as anesthesiologists and intensivists. What's happening? I can't. Okay. Okay, so I'm going to follow this outline. We're going to introduce traumatic brain injury. We look at the etiology, the causes, and we're going to remind ourselves about the Morrow-Kelly hypothesis. We look at the pathophysiology of traumatic brain injury. We look at the types, the different types of TBIs, and how to evaluate them. Clinical decision rules as it pertains to decision making for CT scan in this group of patients. Then we'll come down on the management and outcome of traumatic brain injury. And we'll just have a slide on the long-term management of patients who have suffered traumatic brain injury and have recovered and maybe discharged from the hospital. All right, so by way of introduction, we're aware that TBIs cause significant,
Sorry to interrupt you, Dr. Kobe. Can we? Sorry, we're not seeing the shared presentation. Are we sharing? Are you displaying it, or you're just presenting it? I'm not.
Yes, I'm displaying it. It's shared. I'm sharing.
Some people have started commenting that they are not seeing. I'm also not.
We can't see the slides.
We can't see the slides, sir.
Yeah.
Oh, I'm sharing. What's happening? Because it's showing me that.
No,
we're only seeing your topics.
Okay, let me try again. Sorry. Screen share. Okay, can you see now?
Yes,
sir, we can see it now.
My apologies. I thought I was already sharing it. All right. Shall I start? Let me see.
Yes, go ahead. You can start.
Okay, so I'm introducing traumatic brain injury, and I did say that they cause a significant cause of mortality and disability worldwide, and they account for about 30 to 50% of all trauma-related deaths, with males being more affected than their female counterpart. The front and the temporal areas of the brain are the main areas involved in injuries. More than 50% of TBI related usually occur within the first 24 hours after the initial injury, and about 30% would occur within the first 6 hours after injury. All right. Traumatic brain injury can occur, actually does occur from a bump or a blow to the head or from a blunt or penetrating trauma. During this impact, the brain crashes back and forth within the skull, which will result in bruising, bleeding, and then sharing of the neuronal axons. The causes of TBI are mainly external kinetic forces to the head. This usually occur following a road traffic crash. It can result from interpersonal violence. It could result from falls, and even during sporting activities, our athletes. I remember the Nigerian player a national player who died on the field following a head collision in Benin City some years ago. Traumatic brain injuries are common among young population, and this is usually due to road conditions, while force account for a higher proportion of TBIs among older patient population. Now, just to remind us about the Morokelian hypothesis, because this is important as it relates to intracranial pressure. The hypothesis states that the total volume of the intracranial space should always remain constant, all right? Because the cranium, the skull is a rigid and non-expansive container. So inside the cranium, we have constituents like the brain tissue, the CSF, venous blood, and arterial blood. So because there's no room for expansion due to the rigid nature of the cranium, the constituents of the cranial volume should always remain constant. Howbeit, if there's an increase in the content, maybe in terms of brain tissue, maybe tumor, or in terms of hydrocephalus, or you have the hematoma, for instance, there must necessarily be a compensatory reduction in another compartment and an increase in intracranial pressure. This is important because cerebral perfusion pressure is usually very closely guided or moderated by intracranial pressure. So cerebral perfusion pressure is given mathematically as mean arterial pressure minus intracranial pressure. So when there's an increase in intracranial pressure, it reduces your cerebral perfusion pressure, and that can lead to secondary cerebral ischemia and infarct. And that is why it's very important that the contents of the cranium is kept constant at all times. If there's any increase in any of the constituent, there must be a reduction in another constituent. So, and that's what Morokelian hypothesis is all about. All right, it's important for us to look at the pathophysiology. I need to remove this from here. Do I remove this so that I can see my slide? Okay, great. So, traumatic brain injury actually can have both primary and secondary effects. The primary injury occurs at the initial injury, and this may result in different types of traumatic brain injury, from contusions, intracranial hemorrhages, and diffuse axonal injury. You may not see anything on imaging, and it's also very important that imaging is usually not indicated to assess primary injury. And it's important for us to note that, because the initial injury may not be visible on your neuroimaging. The secondary injury, which we try to manage, following TBIs, usually occur hours, days, or weeks following the initial primary injury. The initial damage, the initial primary injury triggers numerous secondary effects, which result from different multiple factors. Now, the pathophysiology of TBI usually involves two mechanisms. Number one, it involves intracranial inflammatory responses. And this inflammatory response leads to the release of inflammatory mediators such as the cytokines and your free radicals. And these mediators alter our blood-brain barrier permeability. So the permeability alters, and it leads to swelling, edema, and all that we see in secondary injury, secondary consequence of traumatic brain injury. The second pathophysiology mechanism is there's a disruption of cerebral autoregulation system. And we know that the brain is one of the organs that exhibits autoregulation. So when there's an insult to the brain, there's a disruption of this cerebral autoregulation. And within the first 72 hours, there's what we call known as the hyperperfusion phase, resulting from, the vasodilatation of the cerebral vessels, resulting from your inflammatory mediators. Between 7 to 10 days, we have the hyperemic phase, and the vasospastic phase, which become very deleterious, occurs days after the hyperemic phase. So this is the pathophysiology. We have a primary injury that has occurred to the brain due to the primary insult, either a fall or a road traffic crash, whatever it is, and nothing can be done about that. The outcome of TBI actually has to do with the severity and the extent of the primary injury. The secondary injury, of course, days as after, and the things that we try to manage as anesthetist and intensivist. There are almost about 6 to 8 types of TBIs. I just felt, although we are anesthetists, it's important for us to just have an idea of the types of TBIs that you may be called to manage. Generally, TBIs are divided into close injuries or the not penetrating types of injury. And this refers to those that do not, no skull fracture. All right, these injuries do not involve fracture skull. We have the open injuries, or what we know as the penetrating brain injuries, where there's a fracture of the skull, and this leaves the protective layer of the skull, the protective layer over the brain exposed, so the brain becomes exposed. So furthermore, we can have what we call concussion, or concussion rather, and in this one, it usually represents a mild TBI without any gross structural damage, and oftentimes cause secondary to a close injury, a more penetrating traumatic brain injury. This, if you see the diagram on the right of the screen, this is how it occurs. It usually results from an acceleration. The brain hits an object or it falls on the floor, and there's an acceleration of brain substance and deceleration. And this actually can happen often and many times. And we're going to see what we know as the post-concussion syndrome. Concussion cannot be diagnosed with a routine CT scan or your MRI, but we can do special sequential MRI like diffusion tensor imaging, which will lead to an early diagnosis of your concussion. But what happens here is that despite the fact that this may not have any gross structural presentation, if the patient sustains another injury after the first concussion without fully recovering from the initial injury, this may lead to a rapid evolution of what we know as the malignant cerebral edema over a short period of time. And this occurs especially among our athletes. Like I mentioned, the name just escapes my mind now. I think it's Saudi or something in Benin then. And so if an athlete or somebody suffers a concussion and has not given enough time to recover from the initial injury and sustains another one, we call it the second impact syndrome or post-concussion syndrome. And the repetitive injuries that occur to the brain can actually lead to very life-threatening cerebral edema. And that's what we know as the chronic traumatic encephalopathy, the CTE, this is usually a delayed manifestation of repetitive mild TBI. So if somebody has a traumatic brain injury and feels is mild, the patient should be advised to look out for signs of post-concussion syndrome, which may actually rapidly evolve and can be very life-threatening. The second types of TBIs are the intracranial hematoma. And this is what we're all very familiar with. The intracranial hematoma include the epidural hematoma, subdural hematoma, and the intracerebral hematoma. The picture on the right side of the screen actually differentiates between epidural hematoma and subdural hematoma. And it's important for us to just, be familiar with these types of intracranial hematomas. Epidural hematoma results usually from bleeding of the middle meningeal artery and its branches, or a fracture, which can lead to that tearing of the middle meningeal artery, and a lot of times usually acute. There's a blood collection between the skull and the brain, and it gives you the concave nature of the lesion on your CT brain. The subdural hematoma results most of the time from bleeding of a bridging vein, and it could either be acute or chronic. Here you see a blood collection under the dura mater, all right, the false protective layer of the brain. Intracerebral hematoma, you see collection of blood within the brain itself. And these are types of traumatic brain injury that we normally see. I'm sure some of us will have access to this presentation later on. We can have time to look at the differences. The next slide is actually, especially for trainees, because I like asking these questions a lot. So this is just for our trainees to just see the differences between the subdural, epidural, and subdural hematoma. In terms of location, the epidural hematoma faces the trauma impact, while in subdural hematoma, it could be direct impact of deceleration and acceleration. In terms of shape, the epidural lesion is a biconvex hypodense lens, while in terms of the subdural hematoma, it gives a crescent blade shape. Extension, epidural extends, involving the far cerebri and tentorium, but not the suture lines, while subdural hematoma across the suture line, but not the tentorium or the far cerebri. 90% of epidural is usually arterial in origin, while subdural is 90% venous in origin. Most of the times you see epidural on only one side of the brain on CT, but subdural could actually be unilateral or bilateral. And don't forget that, like I said, it could either be acute or chronic. So we can have acute or chronic subdural hematoma, and it could be bilateral. Most of the times, in terms of epidural hematoma, in 90% of cases, we have the skull fracture, while in terms of subdural hematoma is actually an intra-axial injury. Most of the time, contusions where you see pockets of bloods within the subarachnoid space. Over time, we have elucid intervals in 50% of cases, and for subdural hematoma, clinical presentation usually present immediately. All right, so these are just for us to have an idea of the differences between epidural hematoma and subdural hematoma. And you can see more of this from the source where I got this information is on the slide. There are a lot of images that we can practice with. I usually like to give my residents CT brains to interpret, and it's usually very important, especially it aids your communication with the neurosurgeon. We have this traumatic subarachnoid hemorrhage. Don't forget that subarachnoid hemorrhage may be traumatic. The slides on the right shows intracerebral hemorrhage. I don't know if you can see my cursor. This is blood in the within the brain in the cerebrum. all right, while we have subarachnoid hemorrhage all over here, these white patches. So subarachnoid hemorrhage is most caused by trauma and usually results from injury to small capillaries. The blood source will be entering the subarachnoid space. Usually traumatic subarachnoid hemorrhage, usually follows a trauma, and usually occurs over the convexity of the cerebral hemispheres. We also know that there could be bleeding to the subarachnoid space following rupture of an aneurysm. All right, and this usually occurs in the basal systems. The next type of injury is the contusion. I mentioned before, contusion actually usually means a bruise. So when we're talking about brain contusion, we're talking about bruises on the tissues of the brain, and this will lead to bleeding and swelling of the brain around the area where the head suffered the trauma. Contusions may also occur with skull fractures or other blockers such as subdural or epidural hematoma. The Cope and Cope type, the Cope contusions usually occur at the site of impact, whereas the Cope injuries take place on the contralateral side of impact. And usually they occur around the basofrontal lobes and the anterior temporal lobe. All right, so these are contusions, these are swellings, like I mentioned, around the brain matter, the brain substance. And if the brain is stuck here and you have contusions, there is Cope injury, while if there are bleedings on the other side, away from the point of impact, you have the Cope type of brain contusions. Yeah, this is what I don't like, especially in ICU when I need to discuss. Somebody is writing on my note. What's happening, Dr. Dogun? You're spoiling my slides, please. You made some things on my slides. All right, this is what I usually don't like, when a neurosurgeon comes and asking, I say, no, this patient have a DAI, diffuse axonal injury, because there's really nothing to be done. There's no surgical intervention here. And diffuse axonal injury can usually be seen with mild to moderate traumatic brain injury. And it usually potentially results from sharing, stretching, and twisting injuries to the axons, the neuronal axons. And they mainly sit at the junction of the gray and white matter. Remember, the gray matter has dense neuronal axons, but when they're trying to enter into the less dense, less fluid-filled white matter, that is when they are susceptible to stretching and sharing. Now, the sharing forces on the neuronal axons lead to axonal swelling, increased permeability, calcium inflows into the axons, and they can lead to detachment and axonal death, and this can have a very permanent neurological fallout in this group of patients. Unfortunately, most neurosurgeons say that this is not amenable to neurosurgical intervention. Now, evaluation is important for us to have a quick evaluation of traumatic brain injury. And I brought two tools here for us to just consider. The popular one, the Glasgow Coma Scale, which was published some years after I was born by the two professors, Tisdale and Janet, at the University of Glasgow. It's used to objectively describe the extent of impaired consciousness, and it's actually been used both for medical and trauma patients, and it assesses responsiveness in three domains: eye-opening, motor response, and verbal response. And it's important to accurately report the three domains. No eye opening for what, and eye opening to pain, eye opening to sound, eye opening to spontaneously. Verbal response, no verbal response at all, incomprehensible sound, inappropriate sounds, confused, and 5 is when the patient is oriented. Best motor response, no motor response at all, you give 1. When there's an abnormal extension to pain, you give 2. Abnormal exflexion to pain, you give 3. If the patient withdraws from pain, you give 4. If the patient pushes your hand away at the point of inflicting pain, You give 5. You ask the patient to just raise the hands or the legs, and the patient obeys you. You give maximum score of 6. So this is what we are very familiar with in our practice. Then we have the Los Amigos scale, and this scale is important, especially because it assesses patients' cognitive and behavioral presentation after suffering a closed brain injury. All right, and actually this is done as they wake up from unconscious state, and we have 8 levels. The level 1 is no response, and level 2 generalized response, level 3 localized response, level 4 confused and agitated, level 5 confused and inappropriate, level 6 is confused but appropriate, and level 7 is automatic, appropriate, and level 8, which is the highest level, purposeful, appropriate. The higher the level, the better the patient's cognitive functions following traumatic brain injury. It's very useful. The Los Amigos case is very useful because it provides a structured framework for evaluation, and you can track the progress of your patient and identify areas of improvement. It's also good in terms of consistency of communication among healthcare workers. Provides the patient-centered care because it gives a holistic approach to tailor your interventions based on the individual needs. And this is important because, like I say, in predictive value, the higher the score, the better the functional recovery of this patient. And it also helps in planning for rehabilitation. For patients with higher levels, the level 7 and 8, this group of patients will benefit from their responses is appropriate, and you can give them more complex tasks in terms of cognitive functions. Those with lower levels will require simpler activities because they are not, purposeful in their responses. It also helps in family education because when you do this score, they're able to communicate, better with the families, and the families are able to understand the level of progress of their loved ones, and the patient makes it home. All right. For instance, a patient which is level 3 or level 2, you already prepared the as to what should be expected when the patient gets home. All right, so complete the with CBI is very like, taking care of any patients that we want to do in initial evolving. Examination is very important for us to bruises behind the ears, the raccoon eyes, with shows you more severe form of injury. Neuroimaging is important, and the common ones we are used to are the CT brain and MRI. These are things that tell you the degree of anatomical physiological changes that occur from the traumatic brain injury. For direct zonal injury, diffusion tensor imaging is used. Why? To measure cerebral blood flow and activity patterns, you want to use your SPECT, which is the single photo emission computer tomography. Now, I'm starting to bring this in. Though we are anesthetists, I think it's important for us to know what rules determine what patients qualify for brain CT or not. Don't forget that we're in the era of medical aids and people insurance on our neck not to do investigations that are not necessary. So there are some clinical decision rules which allow for initial evaluation of TBI for stratification and also to determine which patients will require CT imaging to evaluate their TBI further. The most widely used is the Canadian head CT rule, which has both inclusion and exclusion criteria. The inclusion criteria includes patients with GCS of 13 to 15 with loss of consciousness, amnesia after a head injury event, or there's a witness disorientation. This group of patients, according to the Canadian head CT rule, should have immediate CT imaging. Exclusion criteria include patients who are less than 16 years old, or patients who are on blood thinners, or patients who have had a seizure after the injury. They're excluded from these rules. The Canadian head CT rule has the high risk criteria, the medium risk, and the low risk. And the patients with no high or medium risk criteria should not be given a CT imaging. All right. But if the medium risk or high risk is positive, then there's a high consideration for CT imaging. All right. So this is important, and it's good for us to familiarize ourselves with them, and especially to decide when your patient should have a CT imaging. There are other rules, the New Orleans rule, which has more stringent inclusion criteria. Patients must be greater than 18, must have a GCS of 15 with a blunt head trauma, which occurs 24 hours earlier, and which leads to loss of consciousness, amnesia, or deterioration. All right. And the Nexus 2 rule recommends CT imaging in any of the following group of patients: patients who are greater than 65 years or older, when there's an evidence of skull fracture, scalp hematoma, when there's evidence of neurological deficit, altered level of consciousness, abnormal behavior, when there's coagulopathy. The Nexus 2 recommends such patients should have a CT brain. The Pediatric Emergency Care Applied Research Network Head Trauma Algorithm, the PECAN Head Trauma Algorithm, is, this algorithm was actually brought to pass by following the research efforts of the Pediatric Emergency Care Group. And it's the best decision tool to determine which of our pediatric population will require a CT brain. And the algorithm is actually online, and I couldn't bring it here. It's something you just enter some of the features of your pediatric patient, and it will tell you whether CT is recommended or not. All right, so we are treatment of TBI. The treatment of TBI depends on the severity of brain trauma. Like I mentioned before, the outcome and the outcome of TBI depends on the severity of the primary injury, and the treatment also is based on the severity and, more importantly, your CT findings. And that's why it's important for us to look at the clinical decision rules to determine which patient merits CT imaging. Now, if there's no hemorrhage on your CT image, or the patient does not qualify or does not meet the criteria for CT brain, then these are the following general management we should do for such patients. For instance, a patient with a GCS of 15 with no local neurological deficit, we classify those patients as mild TBI, and this patient may safely be discharged. Like I mentioned before on the slide on concussion, note that it's possible that we could have post-concussive symptoms, and it's important that this patient be alerted of the symptoms of these syndromes. A patient with a GCS of less than 15 or has any disturbing examination findings this patient definitely will require further evaluation. And this may include further laboratory studies or imaging. Don't forget that CT angio or MRI or is indicated, especially if your non-contrast CT is not diagnostic. So you want to do a CT angio to evaluate this patient in terms of treatment. Now, but if there's bleeding on your CT scan report, you want to follow the ABC line of management, and I'd like to just put it here. So for patients who, there are evidence of bleeding from your CT brain, you want to follow the ABCD line. For patients with the GCS of less than 8 or at risk of deterioration further with subsequent loss of airway, this kind of patients require immediate endotracheal intubation. But don't forget to ensure that you rule out skull fracture so that you will probably be advised on which route of endotracheal intubation you will follow. Don't forget that most of them are trauma patients, so they require endotracheal intubation with rapid sequence induction with cranial pressure and inline mobilization of the C-spine, which is important because many of them, the traumatic brain injury usually associated with spine injuries. So you want to protect the spine once you decide that you want to intubate this patient. Patients with moderate to severe TBI often require oxygen supplementation. And sometimes, in order to ensure adequate oxygenation, you want to put this patient on a mechanical ventilator, starting with FiO2 of 1, using a tidal volume of between 5 to 7 ml per kg until you have your ABG available. And once the ABG comes, you want to change your setting to ensure that you maintain adequate PO2. Know that the aim of mechanical ventilation in TBM is to avoid hypoxia, which is one of our secondary brain injury. And this is also important in as much as you're trying to, improve your oxygenation. You must avoid hyperventilation, especially, initially we knew that we're taught that you need to ventilate this patient to a PCO2 of 30 thereabout. But initially, it helps because it causes cerebral vasodilatation and therefore it helps to reduce the swelling and the bleeding. But prolonged hyperventilation has also been discouraged because it can lead to cerebral, tissue necrosis. Circulation, you want to assess the patient volume status, and you want to restore the circulating blood volume, or it may be to ensure euvolemia. This also helps to maximize your oxygenation. Don't forget that this patient will require A-lines, and your CVP monitoring may be indicated. For patients with persistent or refractory hypertension, despite adequate volume resuscitation, this patient may require some inotropic or vasopressors to maintain cerebral perfusion pressure. And don't forget what we said before, that cerebral perfusion pressure is equal to mean arterial pressure minus the intracranial pressure. So you want to defend your cerebral perfusion pressure by increasing your MAP. Patients' conscious level must be assessed. And in TBI, this is something that must be assessed on a regular basis because a sudden drop in GCS is a cause for emergency neurosurgical consult. So any change in the level of consciousness should be properly addressed and appropriate steps may be taken, which oftentimes required emergency craniotomy. So your neurological examination is important as your initial resuscitation management for this patient. All right, I mentioned neuroimaging. As part of our care for traumatic brain injury, you want to obtain the routine trauma series. Like I mentioned before, you want to rule out C-spine injury. There could be other associated injuries that may actually cause early demise for this patient. All right, so you want to rule them out or confirm them. And some of them may actually require urgent medical or surgical intervention. Patients with flayed chest, all right, patients who have the tension pneumothorax, or patients who have spine or even pelvic injury, all right, or even patients who have blunt abdominal injury with blood trickling into the Morrison patch and all that. These are things that may kill the patient faster if adequate attention is not paid to them. So the trauma series of X-ray must always be done for patients with traumatic brain injury. CT scanning, like I mentioned, is almost the most informative radiological test and is a standard for patients who qualify for it. And that is why the clinical decision rules must be applied at all times so that those who require CT brain are not denied and those who do not are not afforded what they do not need. Cerebral geography can be considered, especially when the information on your non-contrast CT is not as revealing as you want, because you could have the vascular injury, especially carotid artery dissection, and the cerebral geography will just bring this out for you. All right, after you stabilize this patient in the emergency room, patient often is brought to the ICU, and this is where we are called upon to ensure this adequate management of this patient. And like I mentioned, the goal of ICU management in TBI is to prevent secondary injury. There is nothing we can do to about the primary injury. All right, and I mentioned that the outcome of TBI lies likely on the severity or the extent of the primary injury. All right, I like mnemonics a lot. In most of my writings and books, I have a mnemonic. So, and I found out that it helps, especially for the uninitiated medical officer or a resident who is coming to ICU for the first time. If you can just put the mnemonics in your head, it will help you to go through management of the patient in a systematic manner. So, as a matter of TBI, I like to call it head. Don't forget head. All right, head injury, head trauma. So make sure your head is correct in the way you're managing this patient. So the H there is avoid the 4H. All right, the 4 secondary injury. You want to avoid hypotension. You want to avoid hypoxia. You want to avoid hyperthermia. And you want to avoid either hypo or hyperglycemia. So you want to adequately monitor to ensure that hypertension does not significantly increase your patient's mortality. And this can actually be done by
physiotherapy. You will have 5 minutes more to extra time. Thank you very much.
No, I need to run then. I need to run. Thank you for reminding me.
Yeah,
I mentioned some of these things before. Yeah, so in trying to avoid secondary injury, you want to ensure adequate oxygenation. And like I mentioned, you want to avoid hyperventilation. In head injured patients, we use what we call protective ventilation with low tidal volume, and we use moderate PEEP, has been recommended. In most of the times, I tell my people we do targeted ventilation, what I call smart ventilation. So each patient that comes to the ICU requiring ventilation must be goal-directed, must be patient-directed, and must be pathology-directed. So for patients who have suffered traumatic brain injury requiring ventilation, we want to use a low tidal volume with a moderate PEEP. You don't want excessive PEEP in this patient. Hypothermia, like I mentioned, is a secondary brain injury, and you want to ensure that your temperature is controlled below 37.5%. All right, either with aggressive drug therapy, or you want to use aggressive cooling. It's been said that moderate systemic hypothermia, this temperature between 32 to 34 degrees centigrade, reduces cerebral metabolism. There increases, reduces cerebral metabolism, reduces cerebral blood flow, decreases ICP, and thereby increase CPP. All right, but some studies, there have been some concerns about what the degree of hypothermia, and some scholars have found that severe hypothermia is worse than trying to actually maintain homothermia. Tight glycemic control has been discouraged because it has a propensity for episodic hypoglycemia. All right, so what we do, we know that hyperglycemia is actually a poor neurological outcome in this group of patients. So you want to ensure that your blood sugar is kept between 4 to 10 millimole per liter. All right, the E is end of bed elevation. This is something that is very important, because keep the head at 30 to 40 degrees in a neutral position helps to reduce ICP and thereby improve your CPP. And for patients who are ventilator, this also helps to reduce the risk of the ventilator pneumonia. The TBI, you want to avoid agitation by ensuring adequate sedation. All right, and this is important because it improves patients' analgesia, reduces anxiety, and it also allows for instrumentation, mechanical ventilation. Adequate sedation decreases oxygen consumption and carbon dioxide production. And overall, I say it improves patient comfort. I always say in ICU that it's humane to give this patient adequate sedation. Sedation should be ensured in the first 48 hours of ICU admission following TBI. All right, and the common depends on your institutional protocols. But I like the combination of fentanyl and midazolam. I know that some people use high doses of morphine and propofol, but whatever you use, ensure that you give adequate sedation to this patient, especially for the first 48 to 72 hours. The D talks about your anti-seizure prophylaxis, which is important, and the broad spectrum antibiotics, especially for trauma. Others include early feeding with good calorie intake and protein intake. And don't forget that this patient is going to be immobile for some time, and they are therefore prone to DVT. And you must ensure that you either use pharmacological and non-pharmacological methods. Non-pharmacological DVT prophylaxis includes intermittent pneumatic compression stockings or graduated stockings. And we'll note that anticoagulant therapy is only used after 72 hours of intracranial hemorrhage or craniotomy. And you must monitor this patient closely and a repeat CT to detect any expansion of the hematoma. All right, the ICP is something that we need to look closely into in TBI patient. Management of ICP begins with monitoring, and I've seen ICP monitors in 2 places, in India and in Kigali, and I don't know how many of us have ICP monitors. It's very handy and it's important, especially for patients who are hemodynamically unstable, patients who have severe head injury, if the patient is above 40 years, and the patient has either decorticate or cerebral posturing. These are patients that require ICP monitoring. All right, seizure prophylaxis. A lot of times our patients are put on seizure prophylaxis when they come. The risk of patients developing seizure following TBI include lower GCS, less than 10, patients with cortical contusion, depressed skull fracture, patients will have hematomas, the subdurals and the epidurals, patients with penetrating head injury. This group of patients are high risk of developing seizure disorder. And seizure activity may be apparent clinically, and it's important for us to keep a seizure chart for all our TBI patients. When I come for a round, that's what I ask for. I want to see the seizure chart, or sometimes you may want to do EEG. Like I tell my people, the fact that the patient is not having seizure clinically does not mean there are no electrical evidence of seizure. So most of these patients are treated with anti-seizure therapies. Propofol may be ideal, but phenytoin and phosphoenitoin first line, and the levetiracetamine is an alternative therapy with fewer side effects. Prophylaxis should ideally be for 7 days. In terms of raised ICP, the critical value that requires treatment is ICP value of more than 20 millimeters of mercury. But don't take it absolutely. You must also consider clinical and breastfeeding findings. And treatment of raised ICP is also head, like I mentioned. I like mnemonics. The head is there. You want to ensure hypothermia to lower your cerebral blood volume, cerebral blood flow, and you thereby increase your cerebral perfusion pressure. End of bed elevation is important because it helps to avoid venous congestion and promote venous drainage. Adequate analgesia sedation to prevent agitation, and which can also lead to increased ICP. The D, we talked about depressive craniotomy. After patient, there's persistent intracranial hypertension despite medical management, and diuretics in forms of 20% mandatory hypertonic saline. And this is important, but remember that it should only be given after a CT scan has ruled out extradural hematoma. There are a lot of side effects with mannitol, and a lot of times small volume hypertonic saline may be preferable. The barbiturates, especially for management of refractory intracranial hypertension, and you can actually have what they call barbiturate coma. All right, this barbiturate coma should only be done following a consultant decision, and you must also be able to monitor your EEG before you start. All right, 3 ampoules of talpentom, all right, is usually needed, and you give bolus in 10 mils, which is about 250 milligrams. You want to target a 3 to 4 burst suppression per minute. All right, and you start infusion after your bolus. After you have achieved 3 to burst suppression per minute, you start your infusion at a rate of 12 mil per hour, which should be supplemented with reassessment of your EEG every 5 minutes. Now, once you have achieved your burst suppression, you want to gradually reduce your infusion rate and stop midazolam morphine infusion. Oh, monitoring. I think my time is up. Monitoring is important for us in addition to our normal monitoring to have the cerebral blood flow with jugular burst oximetry, SJO2. All right, this is usually done with retrograde placement of a barbiotic catheter, and it's used to assess cerebral perfusion. SJO2 less than 55% suggests cerebral hypoperfusion, and SJO2 greater than 60% suggests aquaremia. And another important thing is that you can use your jugular bulb catheter for ejaculation of cerebral lactate fluxes. And arteriojugular lactate difference of minus 0.4 millimole per liter, or a lactate oxygen index, all right, of greater than 0.08 suggests cerebral ischemia and infarction. Near infrared spectroscopy is like our SpO2 probe, and it usually uses carboximeter. All right, its principle is based on the differential absorption properties of the 2 main chromosomes in the brain, and it's very important, especially to monitor oxygenation. Transcranial dropper is a non-invasive method that is used to measure cerebral blood flow velocity, and it's useful, especially for, don't forget that we said that disruption of cerebral regulation does occur, and the last phase is the vasospastic phase. So transcranial Doppler is very important, is very useful in diagnosing vasospasm with critical elevations of ICP and decrease in CPP. ICP monitoring, intracranial ICP catheter is about the most accurate, and it's cheap and reliable. And another advantage is that apart from continuous measurement of ICP, it can be used for therapeutic drainage of CCL to reduce your ICP. All right. However, the risk of infection is very high, and it's ideal to have the prophylactic antibiotic cover. Outcome and prognosis of TBI. Like I said, the outcome is determined by severity of primary and secondary injury. Patients who present with very low GCS on presentation, patients advanced age more than 65, patients with chronic, comorbidities. We have the extended glaucoma score, which categorizes patients to 8 different levels, and usually done with the use of structured interviews, either with the patient or their caregivers, and this should be performed 6 to 12 months post-injury. So we have 8 different categories. It's either the patient has died due to the brain injury, or the patient is in a vegetative state, unaware of their surroundings. We have the lower severe disability. The patient is conscious, but is dependent on others for daily activities. the upper severe disability, the patient is conscious but can perform some daily activities. Lower moderate disability, the patient is independent, can do a lot of daily activity on his own, but may require help for some complex tasks. Upper moderate disability, the patient is independent in most daily activities, but may have some limitations. The good one is the lower good recovery and the upper recovery, where the patient has made a complete recovery and has no impairment. Long term, we need to plan for rehabilitation of this patient. A lot of times we may not be involved because the patient has left our ICU, but it's good for us to know that most of these patients will need rehabilitation, and options include physical therapy, occupational therapy, and speech therapy. All these depends on, that we can use different scoring systems to do that. Psychological impacts. A lot of times they have cognitive dysfunction, residual neurological deficit, and these patients require some of this support. Yeah, in conclusion, I made it. In conclusion, managing TB and the ICU could be very challenging, especially for our residents and younger colleagues. And easily remember mnemonics such as are presented here could help guide initial care and ICU management of this patient. These are my references. They are long, and thank you very much, everyone. Dr. Rabi, I made it.
Thank you very much, Dr. Toby, for a very wonderful. Thank you. Can you hear me now? Can you hear me?
You.
Yes, sir, we can hear you.
Yes, thank you very much for a wonderful presentation. We'd like to note we notice they are wonderful. Sorry, my network is going bad. We have in our midst several neurosurgeons, Professor Jimo, Dr. Dati. I don't know if I can present it because I can't see my chart is not appearing here. We have some neurosurgeons in our midst. We have Professor Legbe, our mother. She's joined us. So it's a very wonderful presentation. Please, we will take 20 minutes to.
Good evening, Professor Legbe, mommy. Good evening, ma'am.
Yes, we have neurosurgeons, professors in our midst. Professor Abdullah Jimo and two other people. Yes. So please, we have questions and answers. You can put it in the chat, or you can unmute and you can raise your hand and be called to ask your questions.
I think they can raise their hands and then you identify them. But in the meantime, you can ask for comment from the neurosurgeons. So they can say something.
My dear distinguished colleagues from surgery department of surgery, you have any comments, any questions, any contributions? Please feel free to do that. You can raise your hand.
May I?
Yes.
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 Okay.
Professor Abdullah Jimo. Go ahead, please, Professor.
Wonderful presentation. I carefully followed your presentation. It's all encapsulating. And I was particularly excited when I was notified of this, or when I got to know, and specifically notified by Dr. Dati on this presentation. I pass it on to our residents to be part of it. And it's a 1 hour well spent listening to you. Great overview of the whole topic, the clinical aspect, evaluation to the management in the anesthetics perspective. Thank you so greatly. I wouldn't, it's nice. I don't want to preempt the comments that will follow and the questions that will follow, because I know the audience is very wide. I want people to make contribution and ask questions at the other level. Then probably later I'll further comment. Just when Dr. Mohamed Rabiu said that you have 5 minutes, then we started hearing a lot of what we were expecting. Thank you so much that they eventually came in anyway. I really appreciate that. Then I don't want to preempt people, maybe the indication for ICU care, anesthetist perspective, pre-operative, intra-operative, and post-operative, particularly ICU management indication for ventilation, the modes of ventilation, use of steroid, the kind of IV fluid you use for maintenance. I actually wanted to get these things as well. I know it's very wide, extremely wide, very, very wide. You could go on and on to discuss this presentation. Having said that, I think I leave the house to others to contribute robustly. I think it will generate. Thank you so much.
Yes, thank you, Professor Jimo. We thank you for your contribution. We have two hands right now. We have Professor Legbe. Professor Legbe, if you can unmute and comment, ma. You're welcome to
Can you hear me? Good evening.
Yes, we can hear you.
You can hear me. Good evening. Well, Dr. Toby, thank you for the presentation. Now, I kept hearing a few times you talking about adequate analgesia. I think you need to tell us a little more in terms of what you mean by adequate analgesia for a patient that is comatose. What are the parameters and what are the ways by which we go on to assess the adequacy of analgesia in such a patient? My second comment will also be on the use of monitoring intracranial pressure. And I think that is probably more for the books. You might need to tell us a little bit about the role of surgical intervention in the management of intracranial pressure in traumatic. And if I needed any more comments on that, then I'll comment. Thank you.
Thank you, ma'am. Then we have Dr. Ololade Dayosi. Can you unmute and make your comment? Yes.
Yes, sir. Thank you.
Are you on? Is the network problem? We can't hear you again.
I think we lost her. In the meantime, you can recognize Professor Oshinaki.
Okay.
You can distance yourself from another device.
Okay, she's back.
If you have two devices.
Okay.
But she's echoing. Maybe there's another device nearby.
Okay, sir. Hello, sir. Am I audible now?
Yeah, you're clear now.
Okay, thank you, sir. Thank you so much, sir, for the presentation. It was really enlightening and corroborating with what we have been practicing. So I just want to, because there is this issue of neurosurgeons insisting that we should intubate their head injured patients sometimes, and we are concerned about the ventilation. So I don't know, is the practice, is it right to intubate an head injured patient without being ventilated because of our environment? Sometimes there are no ventilators to actually ventilate this patient. I would like to know your opinion on that, sir. Thank you very much, sir.
Thank you very much. We have Dr. Babatunde Yoshinake. Can you unmute yourself and let's hear your comment?
Thank you, moderator. Thank you, Toby, for the presentation. I think you try to cover as much as possible what is relevant. Just two areas, just want to make a comment. And one of those is I want your comment about what do you do in your center, or what do your neurosurgeons do when it comes to anticoagulation after traumatic brain injury? What is your practice? What have you seen in your environment? Anticoagulation. Then I heard that, I mean, you mentioned the tidal volume, maybe I didn't hear you well, 7 to 10 minutes per kg. I think that would be on the high side.
So 5 to 7.
I think,
5 to 7.
Okay, 5 to 7.
I said 5 to 7.
Okay, I think that's fine. That's fine. So maybe just comment about that anticoagulation. Thank you.
Good evening, everybody.
Now, I think the questions I don't want to lose, or I should wait.
Good evening. Good evening, everybody.
Yes, good evening. Please, may we know who is speaking?
Professor Domoye.
Okay, welcome,
my
ma.
mommy. How are you, ma?
Good evening. I want to start by thanking Dr. Toby for a beautiful presentation. Toby, how are you?
I'm fine. So good to hear your voice, ma.
Yeah, thank you. Now, please, for the purpose of candidates going for exams, I know you you spoke about avoiding hypotension, hyperglycemia. I thought probably you would have also stated the choice of fluid for patients with traumatic brain injury, and the fluid to be avoided and the reason. Then secondly, you said avoid prolonged hyperventilation. Yes, and you stated the values for the arterial carbon dioxide tension also. So I want you to expatiate on that. What do you mean by prolonged hyperventilation? Then thirdly, I'm happy we have a neurosurgeon in our midst. Some neurosurgeons, they do not allow, or in short, they go against ventilating. No, if the anesthetic decide to ventilate a patient in the post-operative period, they go against it until it is too late. But except the consultant has to stand his or her ground to say, no, this patient requires ventilatory support in the post-operative period, maybe for the first 24 hours or 48 hours before they allow it. I want you to also say something about that. That is ventilating a patient in the immediate post-operative period, a patient with head injury after a prolonged surgery.
What sort of?
I mean a patient with TBI, you know, after having, with head injury, and then maybe long, prolonged surgery, either not hematoma, not really hematoma, evacuation really does not take time most of the time. But if other procedures are involved and it lasts for a long period, lasts for a long period, maybe there are also other injuries to the brain. You know, some surgeons do not see the need for such a patient to be ventilated on the patient develops respiratory problem, maybe many hours later. Thank you, Dr. Toby.
Thank you. Any more questions? I can see there are some questions on the chat and some were answered. I don't know whether I have to go through all of them.
I think maybe you allow him to respond to this so they don't get many, and then we take.
Okay. It's all right. Go ahead, Toby, and respond to the questions.
Okay, thank you very much. Please help me in case I miss any question. Okay, I think somebody was okay. The Mommy Legbe was asking what I meant by adequate analgesia in patient in coma. Yes, ma'am. Adequate analgesia is very important, especially in order to avoid agitation and the sympathetic responses of a lot of things that happen in this patient. So adequate analgesia and sedation is very important, and especially if we have agents such as the alpha-2 agonist, desmetomidine, which has analgesia and sedative component. Adequate analgesia, there are different ways to assess pain scores in ICU patients, and one of the well-validated score is the critical care pain observation tool, the CPOT. And this is important because it makes use of not just the patient's inability to verbalize the degree or severity of the pain, it makes use of other physiological parameters. The fact that the patient is in coma does not rule out the fact that they do feel pain. So I usually try to incorporate these two, critical care pain observation tool, to determine or assess the adequacy of analgesia for patients in ICU. Thank you. I hope I answered that.
I'm not terribly happy.
Ma?
Because we need more practical side of it. And I believe I agree with you. It's a traumatic brain injury. So there's some trauma. So there's going to be pain. And you've got to consider the pain. But when you say adequate, yes, that becomes a bit difficult because measuring and assessment is difficult. So we have to go on some guided principles. Like you say, for every traumatic patient that comes in, you give 5 milligrams of morphine every 4 hours or 2 milligrams of morphine every hour, something like that, to cover that. And maybe add on etomidate, like you said, he had some, how many of us have got etomidate? I think we should think of something else.
Desmetomidine, I mean desmetomidine.
Etomidine, okay, all right, okay. If that is available, you know. But it's very difficult to monitor, but it has to be a kind of protocol put in place to take care of analgesia, rather than saying we have to monitor. It's very difficult to monitor. I agree with you that you can have sympathetic interactions, but other things could be responsible for those as well.
Yes, ma'am. I agree with you, ma'am. And that's why we try to introduce the critical care pain observation tool, which is like our, the VAS score that we use, but it's different, but it will tell the degree of pain that this patient is having, and that's what will determine the adequacy of the analgesia that is being provided to the patient. It is difficult to give a blanket statement to say the protocol. I believe that each institution should have the protocol, but the protocol should be evidence-based, and that's why I'm pushing for the critical care pain observation tool that can be used in ICU. That, for instance, we know that any VAS score greater than 4 requires analgesia. CPOT level 3 requires analgesia. So if your patient has a CPOT level 3 or thereabout, you know that you need to up your analgesia. So I know it's difficult to assess pain in our critically ill patients, especially those who are have reduced level of consciousness and those who are on ventilator. But I'm very familiar with the critical care pain observation tool, and I think it can come handy, man.
Okay. All right. Thank you.
Thank you, ma'am.
So the second question I have. Yes. Thank you. Go ahead.
The second question I have is from someone who talked about how the neurosurgeon asking us to intubate their traumatic brain injury without requiring ventilatory support. I hope I got that question. Am I correct? Oftentimes, I I tell people the fact that a patient requires airway protection, we need to first and foremost determine the need for the patient. Does this patient require airway control alone, or do we need to invasively ventilate this patient? For patients who require just airway control, and we just want to do endotracheal intubation, we need to also balance the need for adequate sedation and the comfort for this patient. A patient who is intubated and does not have any form of sedation, does not have any form of support, that patient is going to have a precipitous rise in ICP, and whatever it is that has been done may just be rubbish. So it's important for us to understand. And a lot of times, most patients in the settings where we have arterial blood gas analysis done for our patient, will realize that we have objective indications for invasive ventilation. So a lot of times, the practice I'm used to, and they used to over the years, is that for patients who have traumatic brain injury, I like to keep them intubated and ventilated for the first 24 to 48 hours. And it's been found from studies that it kind of helps, in terms of ICP care, management, and it also helps with outcomes. So the first 48 hours of patients suffering TBI, maybe even coming from surgery, such patients are usually intubated and extubated. And like what Mommy said, sometimes the degree, the duration of surgery comes to play too. So I think it's important for us to get our neurosurgeons counterpart on board, that initially for the first 24, 48 hours, depending on the severity of the primary injury and the degree of intervention that was offered this patient, it will be good for these patients to be ventilated for the first 24 to 48 hours. Thank you. Please, can I make an appeal? Somebody is writing on my slide and is defacing my slide. Please, it's defacing my slide. Please help me. Then number 3.
Where is it coming from? Those lines, I don't know. I'm just seeing them.
Benjamin, I think, I don't know who this is. It's just defacing my slide. You want me to go and prepare a new one, please? I think the first one is from the president of Critical Care Society, Professor Shinake, talking about the place of anticoagulation. Yeah, the practice here is we do not give anticoagulation, for traumatic brain injury, depending on the severity, especially for those who have intracranial hemorrhages or patients who have had craniotomy. We withhold anticoagulation for the first 72 hours post-injury or post-surgical intervention. The dilemma now arises, how do we ensure we insist on DVT prophylaxis? And that's why the non-pharmacological means of DVT prophylaxis comes to play. The test stockings and the pneumatic compressive pumps come to play. So anticoagulation is usually withheld for the first 72 hours after head injury or craniotomy. Mommy Adore was asking about the choice of fluid in TBI. The thing is, the risk usually, Professor Shinaki is raising his hand. You want to comment on what I said?
Yes. I think somebody mentioned there's a neurosurgeon in the house. Is the person a Nigerian neurosurgeon?
He is. He's one of our, he's a neurosurgeon in AB. And okay. I think the practice they do is the more stockings and all that. They don't use DVT. They don't do
okay, now let me tell you what has been happening. What Toby said, he mentioned the fact that you want to hold on for 472 hours, which is what the book says. But even when you wait, the ideal thing is that you should monitor the patient with CT, serious CT, to be sure if there are problems with hematoma and things like that, which are often not available in this in the part of the world. So what people do, what neurosurgeons do, and what they want others to do is that they just leave the patient on mechanical prophylaxis, mechanical thromboprophylaxis. And I have seen not one, not two, not three, not four patients, the fourth or fifth day, coming down with pulmonary thromboembolism. In fact, all of them died. All of them died because we just kept them on DVT, kept them on tight stockings, compressive stocking or whatever. So I want the neurosurgeon there to also make comment on this. Thank you.
Professor Juma, are you still on?
Yes, I'm on. I'm listening to the conversation, though disjointly, in a disjointed way. I listened to the penultimate and last person that made comment concerning prophylactic antithrombotic medication and also ventilation, if I'm correct. The practice, yes, as you know, Dr. Mohammed, you are an anesthetist.
And the timing.
On the contrary, on the contrary to the initial comment, saying that the neurosurgeon will say that the patient should not be ventilated. On the contrary, we want our patients to be ventilated, not particularly, in this case, not only TBI, but other cases of maybe intervention that requires ventilation. We always demand that the anesthetists help us to ventilate the patient for the initial period, 40 days of practice, as you've said. So
yes, and that is what obtains. Yeah, yeah.
That's what obtains where?
That's what I mentioned. That's what I presented. That's what obtains. That's what I do.
Yes, but somebody asked that neurosurgeons.
No, I said some.
Okay. So sorry, in my center, we do what he has presented. Then concerning the prophylaxis, we use test stockings. Recently, we get the real pneumatic, intermittent pneumatic compression stockings. Now, because of the fear of rebleed, we don't go pharmacological ab initio, except if we think there is no contraindication to that, but we depend mostly on test stockings. And recently, we've not had any issues with thromboembolism leading to patients dying. I'm talking in line with the last commentator who said that the person that made the last comment who said that 2, 3, 4 patients only on pneumatic stockings end up, or test stockings end up dying. No, we don't have that.
From
PE. From PE, yes. That's my comment. If I got everything, sorry, I'm a bit distracted, but I was hearing some of the comments.
Yeah, that's what he said, I think.
Yes. Thank you.
So, Dr. Toby, any more questions? Any more answers? Questions?
Yes, Professor Edoye, my trainer, said something about choice of fluid in traumatic brain injury. And the basic thing is we want to avoid isotonic and hypotonic fluids, like your dextrose, your plasmolite, and lactated ringers, because there have been concerns with worsening cerebral edema. So we want to avoid that. And, but normal saline and other solutions that have adequate osmolality can be used, but isotonic and hypotonic salines, hypotonic and isotonic fluids like your plasmolite and dextrose should be avoided. And I think those are the questions I got, and unless I missed any that I didn't write. I was trying to write as fast as I could, but these are the 4 or 5 questions that I could get. And I think I need to respond, if I do have time, I need to respond to Prof. Oshinaki. Sorry?
Okay. Yes, go ahead.
Yeah, I think I understand the Professor Naike's concern, and especially with the non-use of pharmacological method for anticoagulation. But the fear there is, after an intracranial bleed or even after a craniotomy, it's the ideal thing is to have serious CT imaging to see the size of the hematoma or the site of the craniotomy. But if we have adequate, especially the intermittent pneumatic pumps, they actually do help. And there are other things that could be done, especially if we can have ICV filter, which helps to prevent the embolization of our thrombosis from the lower limbs. But the thinking is to avoid pharmacological thrombo prophylaxis for the first 72 hours. And I think it's evidence-based. There may be other things that we can look at. Are we able to correctly diagnose pulmonary embolism or cerebral embolism arising from our thrombus formation, for which we want to thrombolize with anticoagulation? Were we able to come to that point that this patient demised because of pulmonary embolism? I think that's something we also need to critically look at. But for all intents and purposes, pharmacological therapy should be avoided for the first 72 hours, post intracranial bleed and post craniotomy. Thank you.
So thank you very much, Dr. Toby. At this point, at this juncture,
no, before we close, I have one more comment about the role of VP shunt in traumatic head injury, because I've had personal experience in managing. I don't know what is the present trend, that we found it difficult in, especially the two cases I managed was in basal skull fracture, and it was difficult to manage the intracranial pressure because each time we gave him adequate things, the cerebrospinal fluid will come out, the whole bed will be wet, and later on we found for days now he'll be dry, and all of a sudden the bed will come out wet again. So the solution that was evolved was to do a VP shunt to control the intracranial pressure. I don't know what is if the neurosurgeon will comment, is there still a role in the VP shunt in the management of traumatic brain injury? You still consider a VP shunt?
Thank you so much, Ma. If I understand you clearly, there is traumatic brain injury. And there is CSF rhinorrhea or autoria, as the case may be, I don't know.
Yes.
Which of them? Is it rhinorrhea? If it is rhinorrhea,
it's rhinorrhea.
Stage, okay, fine.
The whole bed will be filled.
In the acute stage, you won't go shunting the patient. What you do is
it was because it was difficult to control. That was why
so
VP shunt.
What we do, Ma, is to try to evaluate the patient and know where specifically the leakage is coming from. The patient is taking, after adequately making sure where the leakage is coming from. We don't go shunting the patient. Instead, we go do...
They had a fracture of the base of the skull.
Yes, that's what I'm saying.
Yeah, CT scan, and they decided that they are going to do a VP shunt.
No, at that stage, no. We go doing, we go to repair where the skull base repair. Wherever the leakage is coming from, we try to seal it surgically.
All right.
Sometimes we collaborate with the ENT surgeon if we go sphinx, depending on where the fracture is. If it's the frontal sinus, ethmoidal sinus, anterior and posterior cells, then we go and do skull-base repair.
Okay.
But if it is it might be a bit difficult to localize where the leakage is from.
That's already severely traumatized?
Yes. You have to or if there is evidence of like ventriculomegaly, which in this case I don't think there will be, you do external ventricular drainage. But in this or lumbar drain, as the case may be, you can put a drain in the lumbar region, and that can lower the intracranial pressure, thereby allowing where there is a rent in the dura to heal.
Okay.
But mostly we do cranial base repair. We have to go and repair where the rent is. Surgically, yes, we can do that.
Okay.
Thank you, ma.
All right.
Yeah.
So thank you very much, everybody. At this juncture, we've had a very wonderful, a very long, wonderful time. I think at this juncture, I will call on the presenter. No, not the presenter. The president of NSA to take over the reign of M of Affairs. Professor Briggs, are you there?
Yes, I am here. And thank you very much for the good moderation. Once again, Dr. Toby, we are very grateful to you for this exhaustive presentation within the limits of time available to you. We are happy with the delivery. I would like to recognize again our surgeons who took time to be with us here in the light of team spirit. So thank you for joining us and for the cross-fertilization of ideas. We are grateful to you. From East Africa, we also have some colleagues, Dr. Ndaba, Dr. Ntabwe, and Dr. Salim from Kenya. Dr. Ntaba and Ndaba are from Zambia. We are grateful to you for taking time to be with us this evening, and I hope we met your expectations. Once again, I would like to thank our mamas in the house, Professor Donwoyi, Professor Legbe, for standing with us in the language I want to use, Gidigba, and not leaving your children out there on the field. We appreciate you anytime we have you with us. Thank you, Mas. To the faculty chair of West African College of Surgeons, Professor Lori, we say thank you for joining us. Professor Oshunaike, the chair of the Intensive and Critical Care Society of Nigeria, thank you. Professor Desalu, the president of the Pediatric Anesthesia Society of Nigeria, we're happy to have you with us here. And to my own past president, Professor Ogboliwa, so once again, thank you. And Major General Gubi, I saw you. I hope you're still there. We also thank you for standing with us always like a big brother. We appreciate your presence. Dr. Omwekene,
thank you very much.
CMAC, FMC Asaba, thank you for being here with us. Please, I don't want you all to sign out because I find before I finish addressing the attendance becomes just 2 digits. I have an important communication for you, please. I want to please give a special appeal to every one of you who has not been up to date with your dues. Please, please, and please update your dues. And if you're due for membership, for life membership, please do so. Why we are saying this, this webinar, for example, we are doing it all free of charge, but you know as much as I do that we are paying some cost for it. Besides that, we are a member of the World Federation of Society of Anesthesiologists. We have a capitation we are paying in dollars. And I tell you, all those things you enjoy by way of sponsorships, by way of grants, by way of courses, by way of being members of committees. It is all because we are paying our dues as a world body. So I want to appeal to you, and we all know what dollar to naira is now. Please don't be annoyed with this approach of this evening. I have to do it myself to let you know that we need money. Money is the fuel, like you all know, that drives the engine. So on that note, I'd like to say thank you once again to all of you, and please listen to the PRO for the remaining announcements he has to give. Dr. Shole, please, you have the floor briefly. Thank you.
Thank you, ma'am. Good evening, our trainers, our mentors, and our esteemed participants for joining us this evening for today's webinar. We really appreciate you all. I just want to let us know that our upcoming events are as follows. From 3rd to 7th of March, there will be World Congress of Anesthesiology Conference which will be happening in Singapore, and the All African Anesthesiology Congress is holding in South Africa on 13th to 19th of September 2024. Our this year NSA conference, scientific conference and AGM will be holding at Enugu in November 2024. We also want to humbly request from all our participants, the doctors especially, that we should please participate in the terrain study. I've been posting it on this chat box. Please kindly participate by filling the survey form. Thank you. God bless you all.
Okay. Thank you very much, dear PRO. Once again, I'd like to thank the Education Committee headed by our own Professor Dirty. Thank you for the good work you're doing. I'm sure you have a package for us before, because we have World Congress of Anesthesiologists later this month, we will not be having any session until March. So once again, I'd like to thank every one of you, and I'd like to say, please stay in touch and keep praying for us. Please talk to us. Anything you think we need to do better, we welcome from you. And on that note, I'd like to say thank you. Have a lovely evening, and God bless you all.